So my name is Mike Mullen. I'm an assistant professor in the vascular neurology division of neurology here. And it's a pleasure to be here and talk to you a little bit about our tele-stroke program. So there's a lot that I could potentially go through here, but we only have 10 minutes. So I'm going to give you a brief introduction to stroke. I want to really emphasize to you that stroke is a time-critical disease, that access to specialized stroke care improves outcomes, and that telemedicine improves access to specialists for stroke. And then we'll go over a brief case just to sort of demonstrate a little bit of what we do. So acute ischemic stroke. So about 85% of strokes are ischemic. And you can see here we have a picture of a brain, and there are blood vessels going to that brain. And shown in the inset, there's a blockage in one of the arteries going to the brain. And when this occurs, as soon as it occurs, there begins to be damage to the brain. And over time, that damage initially is reversible, and it will then progress to irreversible damage. And when that occurs, it has dramatic and serious implications for the patient, and can present with many different symptoms, but could be things like facial weakness, weakness in an arm or in a leg, difficulty speaking, loss of vision, trouble walking, but serious problems that cause major disability for the patient. And stroke is very common. So there are about 800,000 cases of stroke per year in the US. It's the fourth leading cause of death and a leading cause of disability. Actually, only the minority of stroke patients die. Most of them live with severe disability. And because of this disability, stroke is also exceptionally expensive. It's been estimated that stroke and the disability that comes after stroke accounts for more than $70 billion per year in the US. So time is critical in stroke. So here we have time is brain. Time is brain. This is a major public health message. When someone has a stroke, it's estimated that approximately 2 million neurons, 2 million brain cells, are dying every single minute. And we have therapies. There are things that we can do to treat stroke, to reverse those blockages, to reopen blood vessels, to restore blood flow, and to improve outcomes. But the effectiveness of those therapies are reduced every single minute in a stroke. So every minute that there's a delay in therapy, the chance of someone having a good outcome is reduced. So what we really need is people to identify their symptoms and to get directed to a hospital and a provider that's prepared to evaluate them and treat them very rapidly. And this is a bit of a problem because neurologists are actually pretty rare. This is a map that I'm showing you. This is from strokemaps.org. You'll see the Penn logo here. Brendan Carr and Charlie Branish are PIs behind this project, and Brendan's going to talk to you later today. But this map shows the yellow areas are parts of the US where you can go from calling 911 to a stroke center within 60 minutes. And you can see that there's a lot of the US that is not covered. And a part of that is because neurologists are pretty rare. Estimates are that there are about 10 to 12,000 full-time neurologists in the US, and only a small proportion of them have subspecialty training in stroke. So the local example here is that in the UPHS health system, we have 3 large hospitals. There are 4 people who identify themselves as stroke doctors, and we have some critical care doctors who also have stroke expertise, but it's a pretty small number. And so access to these specialized care providers is very limited. And if you put this into sort of a public health perspective, this map shows you stroke death rates from the CDC. And there's kind of an alarming disconnect, I think, if you look at these maps, between where the rates of stroke death are exceedingly high, especially here in the southeastern United States, and where access to care is, because a lot of these areas, you can see there's very limited access. So this is a major problem. And telehealth and telemedicine and telestroke has the potential to help solve this. In fact, Brendan recently published a paper, Brendan Carr, looking at Oregon, suggesting that telemedicine could increase access to specialized stroke care by 40%. So telemedicine really has a potential to have a major impact in getting specialized care to these areas of the country that have a great need, but currently don't have access. Our program is the PennNeuroRescue program, and it's a hub and spoke model. And the idea is that here at Hub, we're the hub. We work with various hospitals and are available 24/7 to help evaluate acute stroke cases. Our goal is to try to increase access to specialized care and procedures. to support the development of community-based stroke centers. So a community hospital may not have a dedicated vascular neurologist, but hopefully with a combination of working together, we can share our expertise and help them to develop pathways and mechanisms to care for these patients. And then to help inform decisions about transfers, right? Patients, this way we can sort of select the right patients to come to us, people that we can offer therapy to, and patients who can be cared for adequately at their home institutions can stay there. So that's the basic background, and I'm just going to go through a brief case. I'm not going to show the technology here. We actually are going to be set up outside, so afterwards, if people want to stop by, we'll have our card out there, and we're happy to go through and show you the technology and what it actually looks like when we're using this. But just sort of an illustrative case to sort of give you an idea of how this works in real time. So our case is an 81-year-old woman who suddenly develops right-sided weakness and trouble speaking. And this started about 75 minutes before she arrived at the hospital. So it was about 75 minutes from when the symptoms started to when she got to that emergency room. The emergency room doctors at the other hospital saw her. They were appropriately concerned about stroke. They activated the Tele-stroke system. Tele-stroke, she was being evaluated by a Penn vascular neurologist within 45 minutes from the time that she arrived at that emergency room. So the idea is that 24 hours a day, 7 days a week, every single day of the year, we're available. And we're available immediately when someone calls us. With the Tele-stroke system, we have a camera. We're able to see the patient, examine them with the assistance of a nurse at the local hospital. We can see that the patient is awake but not able to speak. They have what we call a global aphasia, which means unable to get out any words, unable to understand what's being said to them. A right homonymous hemianopsia, meaning they're unable to see anything on the right side of their vision in either eye. And a right hemiplegia, so they're not moving their face, their arm, or their leg at all. And this number, this is an NIH stroke scale, which gives you a sense of severity and just says that this was a severe deficit. The stroke neurologist with the REACH system, we can also evaluate imaging. So we're able to pull up their scans and look at their CT that was done at the local emergency room. And we can see, most of you are not used to looking at this, but there's a little bright spot right there. And to a stroke neurologist, that is a very important finding because that's a thrombus, a clot, sitting in the middle cerebral artery. And we know that that's what's causing this patient's symptoms, and that if that clot stays there and that vessel stays blocked, this person's going to have a very bad outcome. Because of the REACH system, we're also able to look through the patient's labs and their vital signs, and we're able to identify that this patient was on Coumadin, a blood thinner, and that their blood is too thin for standard therapies. So they're able to quickly identify a contraindication, but then also to realize that we have things that we can offer this patient here, specialized devices and procedures. The patient was emergently transferred to HUP by helicopter, and this is an angiogram, so basically dye into the cerebral arteries, and you can see on the left that there's a cutoff here, that this blood vessel is blocked, and then a special stent-assisted retrieval was used to remove that clot, and now what was previously blocked is now open with normal flow distally. And as a result, the patient did a lot better. She was able to speak, she was able to move her right side, not completely back to normal, but dramatically better than she was previously. The stroke neurologists here were able to initiate optimal medical therapy for her, and she was then transferred to acute rehab closer to her home. So I think this really nicely demonstrates some of the benefits of telemedicine, and the idea was that we're able to see the patient, to look at the scans to identify the problem, to correctly identify indications and contraindications to standard therapies, to identify patients that would benefit from being transferred to us, and to then rapidly get them here, and then the patient ultimately had a better outcome. So our program now is sort of in its infancy. We currently have 3 spokes. We have plans to add 3 additional spokes and hope to continue expanding. The goals of our program, as I mentioned before, are really to support high-quality stroke care and stroke center designation at affiliated hospitals, to improve rates of treatment with intravenous TPA, which is a standard acute stroke therapy, and to identify patients that would benefit from coming to us for more aggressive care. And there's a lot of potential here in the future, I think. A lot of tele-stroke has been related to acute therapies, but there are opportunities to think about identifying patients for clinical research at other sites, to think about the subacute evaluation of stroke and TIA to make sure patients are getting access to sort of subspecialized vascular neurologists, and to think about telehealth and telemedicine and all the great things we're hearing today about secondary prevention and maybe even rehabilitation.